So hello everybody, my name is Gill from WALX and welcome to the first of our winter expert webinars for 2025. We're really excited to have a great guest with us today who has got a huge amount of insight to share with us about managing exercise for people that are living with Parkinson's. And so I'd like to say a big hello to Beccy. Where are you, Beccy? Do you just want to say
Come
hello?
off mute. Hello, hi.
Hello, yeah, take yourself off mute. So Beccy is going to first of all do a short presentation with some facts and figures, and we are aiming this session at everyone. So you might be friends of somebody who's living with Parkinson's, you may be living with Parkinson's yourself, or you may be a fitness professional or instructor who runs groups with Parkinson's. So a broad church of people that tend to follow us here at WALX, and Beccy is happy to take questions. We've had a huge response to the questions and we've already had a chat, and if we get through too many tonight and those that I've had sent in, Beccy and I are going to make sure we get together and just run through them all and create another little recording to make sure nothing gets missed. So don't hold back, keep asking those questions. So before Beccy presents, let's just have a little introduction. Nobody wants to do this, so Beccy's asked me to do it for her. So Beccy, you qualified at Notts University, the Faculty of Physiotherapy, I believe. And then you came down to work in the Berkshire area, where in 2015 you started the Exercise Hub, which is something that's supported by Parkinson's UK and brings professionals together to look at excellence around physical activity for people with Parkinson's. And you, since for about 15 years now, you've been involved with the Berkshire branch of Parkinson's UK, and that's where our paths crossed with pole walking. You were one of the very early groups that embraced pole walking with our instructor at the time, Janine. So that goes back a long time. So hopefully I haven't missed too much there in your bio. Anything you wanted to add to that?
Thank you, Jill. No, that's brilliant. Bless you. No, that's
okay.
Just
Fantastic.
for people who need to know these things. So yeah.
Yeah, so what we're now going to do, I'm going to hand over to you. If you do your presentation, Martin and I will watch the chat coming through, and when you've finished, we'll try to group things into the relevance of what you've just said and what was pre-sent into us. So I'm handing over to you, and I'm going to mute myself.
Bless you. Thanks so much. Great. I'm just going to screen share. The problem with my screen sharing is that then I get to lose all your faces, which is a real shame. So I'm just going to keep waving at you all until every so often. Can you see that all right? Is that, it looks like that might need to be a bit smaller. Is that a bit easier?
No, that's working fine, Beccy.
Brilliant. Great. Well, we'll go from there and then we'll see how we go. Super. I'm going to continue to share. Lovely. Happy? Martin's going to give me a thumbs up and we'll get going. Great. Okay, so it's a real privilege to come and speak to you all tonight. I am really passionate about this area because I think we make a big difference. So there'll be a percentage of you, obviously, that are instructors, and I love you. And as you say, Janine and now Maria are Nordic walking instructors that we've had, pole walking instructors we've had at our Bracknell branch of our Parkinson's UK exercise groups for ages, because early days we just realized how important it is to keep people walking, and there's loads of things about walking with the poles that is hugely beneficial. So I have some in my car. I get them out all the time with patients, and I see patients, 4 sessions as a kind of initial, we call it a PDMOT, and always in those 4 sessions, one of my sections is let's get you, have a look at your walking, give you some poles, and let's see what that difference it makes. And we'll talk about, with some it does, some it doesn't, and we'll talk about that, why that might be. But yeah, really brilliant to come and speak to you. So I'm not a researcher, I'm not a academic, so you're going to get the kind of layman's version tonight, and then I've got some brilliant friends. If you want a little bit more highbrow information, I can pass you on to Julie Jones and many of my mates from the Exercise Hub. But what we're going to do tonight is just talk about the why. I'll share that with you actually. So we're just going to talk about the what is Parkinson's, just briefly talk about that. What would I see as an exercise provider? I'm just going to obviously talk to, I know there's people in the room may have Parkinson's or people who know people with Parkinson's, but it'd be great to talk to all of you that are exercise providers, because you can do loads about it, and it'd be great to talk to you about the how. And then I'd love to signpost you at the end of the session. There's loads of great information out there to help with your knowledge, learning more. The more you learn about Parkinson's, the more fascinating the condition is. And I'm still like right at the tip of learning, and I've been doing it for about 15 years, if not more now. So yeah, let's go on that journey together after tonight. Right, so what is Parkinson's? Well, Parkinson's is a really interesting condition because it affects the middle part of our brain. So there's a section in the middle of our brains that is to do with balance and coordination of movement, and it involves looking after motor movement. We call that motor function, and also some non-motor functions. So Parkinson's is this really complicated condition because there are some obvious motor changes, so movement changes, but also there's a load of non-motor issues, and they can be the ones that can scupper your session pole walking as much as the motor ones can. So the non-motor and the motor issues are key in this condition, which is why it's so complex, because there's lots going on. There's a clever part in the middle of the brain called the basal ganglia, and that is the kind of coordination HQ of our body, and that's the part that's being damaged over time with Parkinson's. And what happens is you've got these this really clever chemical called dopamine, and dopamine helps messages get across from one neuron to the other. So I talk about a bit like being a lake of dopamine, and you've got these islands, all of the nerve endings, and the impulse needs to, you think you want to move, so the impulse goes from the thinking I need to move across the gap to the motor neuron that's going to move your muscle, which then will move. And in Parkinson's, that lake is drying up, which means you cannot get the impulses across from one island to the other and get them down to where they need to go, and vice versa. So information coming back up to the body gets confused as it gets into that basal ganglia, because the coordination element is disturbed by this lack of dopamine, that the lake is drying up. So that for me as a physio, that's important, because the motor control elements, then this coordination problem causes a good few issues, and we'll look at those. But obviously there's loads of non-motor things, so we'll talk about those too. So that's how the symptoms occur. So it's this middle part of the brain, and it's all about the coordination of movement when we're talking about today. So this is interesting. I find this really helpful. So to be diagnosed with Parkinson's, quite a lot still clinically, people just get diagnosed by the consultant neurologist taking one look at you as you walk in the door and going, yeah, okay, probably know what that is, because there's certain things that they're looking for. But to be sure, there's a scan called a DAT scan. Not everyone has that, because if your consultant thinks you've got Parkinson's and then you begin on the medication and you're much improved, that's a kind of 99.9% chance that's likely to be a Parkinson's condition. So they don't always use this, but this is quite handy. And what it's showing is this basal ganglia, this middle section, and dopamine producing cells, they can tag them with these radioactive isotopes. So you have that injected in, and then they take a scan of your brain, and this is basal ganglia. And if you're losing dopamine producing cells, you lose the end of the comma. Can you see there's a comma on? So we're obviously cutting the brain down the middle, which is why you've got these two halves of the basal ganglia, and you lose that comma. And depending on if you have more symptoms on one side than the other, you'll lose that opposite tail. So you can see the positive scan shows you've really lost the tail of the comma. So that's a really helpful way for us to just make sure that we're hitting the right thing. We think it is Parkinson's. There are some other Parkinson's type conditions which will show up too. So yeah, it's not, but it's a really good test. Okay, so I just want to show you. So some people will come, if you're an exercise provider, will come to you and they'll look really good and they might not even tell you they have Parkinson's, because lots of people are like, don't really want people to know, especially in the early stages. It's just quite interesting to note what's going on. So I just wanted you to have a look at this. So he's walking really well, really fit and active, looks good, but there's a few things going on. You might notice, no, the clever thing would be able to do that again. There we go, let's see. So you might just notice that left arm. Can you see that's a little bit tighter, not moving quite so smoothly? He's got a tremor, hasn't he, in that left hand. The other thing that you might notice is he's not moving his trunk at all, so very straight. He's not twisting. When we walk, we move one shoulder forward, the other shoulder forward, because our trunk is moving to compensate for our leg coming forward. In Parkinson's, that's not happening. You get very stiff trunks. So Parkinson's, really, often the stiffness comes centrally first. So trunk is a really good place to look and see, hey, how stiff is that? So he's lost that rotation, which means he's losing that arm swing. A real common problem with people with Parkinson's is they lose the arm swing. And for you guys who are pole walking training, you're like, come on, get that arm going, And the problem with that is that actually it isn't the arm that's the problem, it's the trunk. So because you get stiff centrally, you lose the rotation, the arm comes along for the ride. When you're walking, it's actually a passive movement and it just swings because the trunk's swinging. So the problem with that is that in Parkinson's, you've lost the trunk, which means then you've lost the arm. So rather than trying to get them to shove that shoulder all the time, give yourself shoulder problems, it's looking at, can we get some movement back in the trunk? And that's to do with this stiffness that you get with Parkinson's. So anyway, that's just a quick kind of a reminder that, you know, early days with Parkinson's, people can be diagnosed right from young onset, as in their 30s. That's rare. You know, we tend to see people more in their 60s, 70s, 80s. It tends to be different presentation. As if you're young onset, you tend to have some more problems with certain types of stiffness. So there's slightly different types of Parkinson's as you hit kind of different diagnosis regions of the, you know, as you get older. But so that's good to know. But they can be really young, really fit, and we keep them really fit. And so it's really good to know. You guys are brilliant at that, because you'll get them out, get them walking. So a little bit later down the line, just to show you, this is a little bit more what you might see in your groups. So obviously the tremor is that coordination. The muscles aren't coordinating well, which is why you get that tremor. It tends to be upper limb. They can often get it in their legs. You get restless legs, which is really annoying. So good. They like walking because it gets that moving. The stiffness we're talking about, so this coordination of movement. So this gentleman especially, you can see on that right side, that right leg really doesn't want to come through. And it can be because the coordination means that muscles aren't being switched off. So a real problem in Parkinson's is that muscles are staying switched on when they should be switched off. So in this case, the hamstring on that side, I just have to show you again, if I can get away with that. The hamstring on that side, oh no, is stopping that right leg coming through. He's really having to work hard to bring it through. So it's the switching on of muscles, especially things like the hamstrings, triceps at the back of the arm, means that they can't bring that leg or that arm forward. So it's not always a problem of muscles being switched off. It's normally a problem of too many muscles staying switched on. Great, okay, so so we talked a bit about the motor functions. You've seen a few of those there. The muscle rigidity we talk about, so that's that switching on of muscles. So muscles are switching on too much, which is why you get this tightness. You can have other problems with that, things called dystonia, where you get this kind of moving of a joint that stays in a flex position. That can be a real problem for them. So movement's great for that. It gets it moving. Dystonia. You get a problem with a loss of strength. That can be because you've just been deconditioned because you haven't been moving much, but it also can be, we often say you lose the power up behind a movement. You can't quite produce the right amount of oomph behind a movement. There's some good technical terms for you, but also I think there's a lot to do with body awareness. So you lose the ability to really know what your body's up to. So you're not quite sure whether or not you have bent your knees low enough to then be able to push up to jump. So things like they lose that ability to explode up, they lose that speed, and partly it's that because they haven't got the power up behind that stepping, and that's to do with partly the coordination of the muscles that can't quite get the oomph behind the muscle coordination to really give a power behind a movement. And also we do think it might be to do with this body awareness. So the funny thing about Parkinson's is that because the information coming up into the basal ganglia is getting confused as it gets up there, and then it's sending the wrong information down, they do find knowing where they are in space can be a real problem. So balance, therefore, is a super important thing to train with Parkinson's, because you lose your balance because your body's not quite sure where it is. And especially we find where you put your foot. So people often find that they're bringing their foot across their body, not realizing they're doing that, or the foot might not sit because it's quite stiff and quite tight, doesn't sit nicely on the floor, it tends to come down all in one piece. That's really hard for your balance if you're not moving smoothly. So yeah, the information coming up, we call that proprioceptive information, is getting scrambled as well as the information going down. And then these non-motor functions, the dysfunctions like blood pressure. So low blood pressure can be a real problem, or labile blood pressure. So it goes up and down. So they can suddenly be really high, suddenly be really low. People get real problems with postural drop. So they stand up and the blood pressure goes really down and they feel really faint. So that is a big pain. So yeah, definitely worth keeping an eye on, especially if you're walking. Bladder and bowels, real pain. Because the bladder and the bowel obviously are both muscles, you get the same problem with coordination of the muscles. So constipation is a problem, which is why walking's so great. And yeah, so it is important to keep exercising, partly because it does help your bowel movement. And then cognitive changes. Some people with Parkinson's don't have any significant cognitive impairment. Other people with Parkinson's will end with more cognitive impairment, so Parkinson's dementia, we call that, than others. So it's a really interesting development. I think over time they will diagnose almost Parkinson's or split it into groups. Some people say it's great to keep Parkinson's all in one, because you get this real power behind the name Parkinson's, which means you get more funding for research, more people, there's more groups, you can all go along to Parkinson's UK charity, get loads of information. So there's kind of health in a big group of people. But then equally for clinicians, they're saying, hey, there's some types of Parkinson's which are much stiffer and slower. That's the kind of classic, we call it bradykinesia when it's slow. So that's classic bradykinesia. You get people with tremor as their main issue, get people that have cognitive issues as their kind of their most progressive issue. And then we've got another set, we call them Parkinson's plus conditions. So things like MSA and PSP and CBD. So they're another group again. If you've heard any information about all the stuff around the salt path, that was interesting, wasn't it? So officially, according to neurologists, he had this Parkinson's plus condition, and they tend to be a bit more rapid progression, which I think is why the debate was on. So yeah, so really interesting about, do we keep it big because there's safety in numbers and the funding, or do we really split it down? And you'll see that in the people that come to you with Parkinson's, they'll all be different. Nobody is every individual is completely different with Parkinson's. And so it's brilliant to treat as a clinician, because every day is interesting for me. I'm learning something new every day. Great. Yeah, a few other things in there. Speech. Obviously, your speech is a muscle too. All these muscles, coordinating muscles, is hard. Their voice tends to get much quieter. So getting them to speak out and to sing with you, or shout 1, 2, 3, or whatever you're doing when you're teaching in classes, that's brilliant. So get them to use their voice. Right. So that was lots of information. There you go. Just this is quite useful to know. There's different ways of treating Parkinson's with medication. Basically, there's very little we can do to halt Parkinson's at the moment, and therefore that is what everyone's working on in the research. So the two things at the moment that we know work is medication The best medication is the one that was originally found back in the 50s to make a difference. So it's crazy. We haven't really improved on it since then, because it does really, for those that it works really well. It doesn't work for everyone, but it's called levodopa. So we call it L-dopa. It comes in different forms. So your clients might have Sinemet or Madapar version, co-cardopa. So there's loads of different brand names, but that is synthetic dopamine. So it's just replacing the dopamine that those dopamine producing cells have died off, which means they haven't got so much dopamine in the system. Dopamine agonists are the other group. They often start newly diagnosed patients on these first. So they stimulate the dopamine receptors. So make the dopamine that's in the system more efficient. So it gets to the place it needs to. It gets picked up quicker. So dopamine agonists. And then another group of drugs just slows down the breakdown of dopamine. So the stuff that you've got left, the dopamine you've got left, you don't want the brain breaking that down too quickly and getting rid of it. You want to keep it in the system for longer. So that's why these things like rasagiline, selegiline, apicapone are really handy. So there's 3 different things. Most people tend to go on a levodopa regime. And then these are the other ones are the agonists, and the inhibitors are kind of extras, but consultants play around with these drugs because everybody is different, and different regimes seem to work for some and not for others. So there's not really a massive standard apart from levodopa works. They often use a dopamine agonist as much as they can, because we'll just talk about that quickly. The medication, the dopamine, replacement dopamine, does cause problems. So over time, your body becomes and they say in about 80% of cases, your body does become sensitive to this levodopa, and you can get other problems. So some people get them straight away and they find they can't tolerate the levodopa. Most people find over time these problems occur. But would you rather be stiff and slow and not moving, or moving well, for the next 10 years of your life, and then maybe come up against some of these things? So it's a really interesting debate, and different people choose differently. And it's really good when the patient kind of gets that authority to make those calls, really, because it's their body, and they're going to, it's their body for a long while. So what we find is the main problem when you're walking patients will be dyskinesia. So that is this writhing movement that comes on because of the levodopa in the system, this synthetic dopamine, and you get too much movement. So it tends to happen at part of the cycle of their medication. You've got to take medication quite regularly with Parkinson's to keep these dopamine levels up. So to start with, you might just take it twice a day, 3 times a day, but over time that you wear off, this wearing off we call it, which is why you need to take them in shorter time periods. So it might be 4 or 5 times a day they're taking meds. It's a blimming pain in the neck for them. And if you're with them for a good long time, in the classes that I have, we've got buzzers going off all the time because people have different regimes. So yeah, you'll be used to having buzzers in your groups if you've got lots of people with Parkinson's. But yeah, so dyskinesias is a real problem for them. It means that they don't quite get those feet where they want when they're walking. But just as much as you can, keep them safe and keep them on their feet and keep them moving. And depending where they are on their medication cycle, you might say to them, hey, maybe let's have a think on a day when you're coming pole walking with me. Let's maybe, have a go taking your dose a bit earlier, or taking something to kind of keep you on a good steady level. And they'll already have worked that out, but it's a good conversation to have. Great. Okay. So that's the sad bit, but there's loads of things you can do. So it's just worth having a think now. If you've had any clients with Parkinson's, have you noticed any of those issues? These non-motor symptoms can be as important because of things like fatigue. So fatigue, if you're having to concentrate harder to coordinate your body, you're going to get tired much quicker. So I'm always saying to patients, work hard and then have a good rest. Switch that brain off. The Parkinson's nurses will often say, 40 minutes, really good after lunch. Just turn your brain off. Go rest somewhere quiet. Don't go sleep for longer than that, because obviously then that gets you into a different sleep pattern. But it's really important to just give your brain some time, because it's harder work taking all these things you used to do subconsciously. You're now having to consciously coordinate, which is why patients get tired quicker. So yeah, things like bladder and bowel, you know, if they're getting really anxious about where the loo is, all those things are really important and worth a conversation. Definitely. Right, so okay, so we know the two things that make a difference with Parkinson's is exercise, hooray, that keeps us all in a job, and medication. So I talked a bit about the medication, so exercise. There's been loads of research going on over the last 10, 15 years because they realised that people who were exercising who had Parkinson's seemed to be staying on the same drug regime for longer. So there's some really good research done in the States more recently on a kind of longitudinal studies, and they were like, why is it that patients who have a steady exercise regime pre-Parkinson's and then once they've been diagnosed with Parkinson's, they were up to 5 years being able to kind of stay on the same meds, whereas others in their same cohort were having to go up on the medication because they were discovering more issues. So there's something about exercise, and I'll talk a bit about why that is. So the other thing about exercise we know is it reduces the risk of deconditioning. So if you find it hard to walk, you're not going to walk so much. So patients, even prior to being diagnosed with Parkinson's, about 40% less do less movement than they did, 5-10 years before, or compared to their people at the same age as them. So there's something about deconditioning. When life's tough and you find movement tough, you tend to do less of it. That's a real problem. So we need to make sure that we're keeping people exercising, keeping them moving, because it stops things, reduces the problems like we see, like rigidity and some of these other issues. The exercise drives neuroprotective changes in the brain. We'll talk about that in a minute. What they're realizing is there's something to do with exercise that means these people who were exercising at a higher level than their colleagues were getting better, because it wasn't just that they were keeping their bodies back moving well. There's something going on in your brain that means that actually that's supporting your brain to keep it healthier than those that weren't exercising. We'll talk about that. And then the last area for exercise that's been well researched is how what a brilliant effect exercise has on your mental health and your quality of life. What we know is that people, especially in a group situation, it raises their mood. It produces serotonin when you smile at someone in a group situation, which is why this is a terrible thing, Zoom calls, isn't it? Because you don't get to smile and interact so well. You produce serotonin, dopamine, if you're in a group situation and you're smiling at each other. How perfect. What a brilliant way you're exercising and you're producing more of the things that you need in your brain while you're doing it. So there's loads of reasons why exercising is important for your quality of life. And we know anxiety is a huge issue with dopamine. Without a lack of dopamine, dopamine is a mood enhancer. So if you don't have dopamine, your mood is going to drop, and that can be a real problem. People with Parkinson's find it really hard to get motivated. They say so. Dopamine is the motivation behind doing things. So a lack of dopamine means it's really hard to be motivated to get up and get going, especially for things like classes. So being routine with a class is brilliant because it means they're not thinking, they're just doing it, even if they don't feel like it. So loads of references there. I thought really important to have a read of things if you'd like. So I'll leave this presentation with the team and you can have a read of some of those. Yeah, here we go. So this is the really interesting thing. So last 10 years or so, they've been looking at mice studies and seeing that mice that exercise at quite a high exercise rate. So we call that high intensity exercise. So 70 or 80% of your heart rate max. So you've got to get puffy. So we talk about in our clinic, we talk about are you getting puffy when you exercise? You've got to get to the stage where you can't speak in a full sentence while you're exercising. That means you've really got the heart rate where we want it to be to produce these chemical changes in the brain. And what they realized is mice that they were doing that to, they sent them off on some complicated cognitive challenges. And the mice that had been exercising more were much quicker at completing these cognitive challenges. And when they looked in their brains, they realized that they had this chemical called brain-derived neurotrophic factor, BDNF. That has been, they have more of that in their system than those that were, the mice that were chilling out. I don't know if that was on sofas or how they were chilling. But yeah, so they realized that this clever chemical called BDNF is a really good brain fertilizer. So what it's doing is it's protecting, they think some of the brain cells, it's got this protective factor. There's this clever thing that the brain does, which is neuroplasticity. So if your brain finds that there's a pathway that's blocked, it's really clever at working out a way to go round. So almost like a traffic jam, it works a way to go round. So BDNF is really helpful at helping this growth of nerve endings to get round a problem. So neuroplasticity. So your brain has got this plastic component that can change. And then this neurorestoration, it's keeping everything as healthy as possible. So it has this kind of fertilizer reaction. But you only produce BDNF when you're working at these high exercise rates. So you have to get that heart rate up and you've got to get puffy. So from when I first started treating Parkinson's patients like 25 years ago, we would be like, oh, their balance is terrible. We better sit them down. We don't want to do too much. We don't want to overstretch them. They're a bit stiff. They're going to pull something. To now, we're like, right, come on, you lot. We got to get you moving. The evidence says, we'll talk about that. So the evidence says 150 minutes of high to moderate intensity exercise a week. So that's, we say, 5 half-an-hour sessions a week. The more recent evidence is it doesn't matter how short an amount of time you do in the week, as long as you make sure that you can get that, get a good percentage, so that 150 minutes in. So you could even do like 2 minutes sit to stand challenge after a meal, head up and down the stairs 2 times rather than just the once. So during the day, just getting that heart rate up makes a huge difference to this ability of the body to stay healthy with Parkinson's. So it's interesting work, and it has really changed the way that we work. Okay, so let's just go through this. Yeah, just a reminder, really, just to recap. So Parkinson's on a motor level. So for us, we're talking about pole walking. It causes problems with coordination. That's what we're talking about. So it messes up your switching on and switching off of muscles, which is why often muscles are switched on and not switched off again, which is why you get that rigidity, that tightness, that stiffness in the trunk. You get that slowness because you can't move through. It's like, walking through treacle because your hamstring's not switching off, which means you're not being able to step through quick enough. So that slowness is often to do with not switching things off or on. That stiffness we've talked about. The loss of power behind that movement, that inability to really coordinate the whole oomph behind a movement, that's a real problem. Getting up out of a chair, if you've got Parkinson's, you'll know this, or if you know people who have, getting out of low chairs, blimming IKEA sofas or, restaurant chairs can be really hard because you lose that ability to be able to calibrate what a big movement feels like. And then this understanding of where your body is, this proprioceptive changes, and this vestibular change, not having the information coming up to your brain correctly. It gets scrambled when it gets there. That's a real problem for your balance. So that's what we're looking at. So what we're going to do about it. This is my favorite poster. You can find it. I've put the string down there. It's the American College of Sports Medicine. So if you look up American College of Sports Medicine, their Parkinson's exercise recommendations, there's a second bit to this poster, so you can have a look at the whole thing. This is very similar to the research that we did back in 2015 with Parkinson's UK, looking at what's the research saying, what's the most important type of exercise to do for Parkinson's. People are always saying, but what must I do if I need to do exercise? What must I do? So here we go. So aerobic activity, really important because we want to get this heart rate up. We want this BDNF in the system. Strength training, really important. What we've found with patients, as we said, is they're already deconditioned on diagnosis. So we need to get them back up to kind of baseline and then keep them strong. You're 5 times more likely to become osteoporotic with Parkinson's, because Parkinson's, they think the origin of why Parkinson's might happen is it's a you struggle to, well, some things involved in the gut, basically. And so one of the problems is that you can't absorb calcium like others. So not being able to absorb calcium obviously means that quicker on you're losing the calcium in your bones. And so there's a big Parkinson's UK push to get people with Parkinson's to the GP to get them checked over for osteoporosis. There's some ways that they can do that, and you can scan for that. So definitely be on at the GP, or if you've got people in your groups, really good to just double check with them. Are you on the right medication? Do you know if you're osteoporotic? If not, it might be worth going to be checked. And then there's some medication, some treatment that's really important for that. And strength training obviously is brilliant for making sure we're keeping everyone strong who's osteoporotic. Balance and agility, multitasking, they call it. We tend to call it dual tasking in the UK, but basically this whole idea of knowing where your body is in space, really important. Parkinson's really struggles with turning, because that's a really complicated coordination of movement, isn't it? You've got a head turn, you've got things working on where your balance is. So anything on a turn is tricky. So early days, getting people to work on that head turning. So can your body manage to head turn, stand on one leg? Can you tandem walk? We love a tightrope walking, really good practice. Can you reduce your base? So make that kind of step smaller, and can you still manage to balance? You guys do brilliant things with the poles. Love all of the I do a load of balance exercises, tandem walking with the poles, rotate with your pole at the same time as you're walking on a tightrope. Really hard. I can only just do it. Really good to practice, especially early days. So make sure, lots of balance. The dual tasking element is because of this problem with coordinating. So it's hard for the body to do a motor task, so do a movement, and a cognitive task at the same time. So you might find it's really hard to talk and walk. So if you've got someone with Parkinson's in your group, it's really important that if you want them to be practicing their technique, you probably just need to be really quiet next to them because if they chat to you, might well be it puts them literally off their stride. But what's happening is it's hard to coordinate a motor task and a cognitive task at the same time. And two motor tasks are hard. So this is why we talk about some people find walking with poles really hard with Parkinson's, because they can coordinate their feet. But if you're asking them to coordinate their upper limb as well, it's just one too many things for the brain to work out. So they tend to be out of sync with their arms because they haven't got that reciprocal gait pattern left subconsciously. So it has to become a conscious thing, and then that's really hard to maintain. So some people find Nordic poles much better, because then they're better for balance. We can get that high intensity, can't we? Because we know that you're working harder, cardiovascular, you're working harder with the poles. So it's all brilliant, apart from if you're at the stage with your Parkinson's where you blimming can't coordinate that upper limb. I often give people one pole, so they're better maybe with one. And sometimes you just have to call it a day and say, hey, just come for a walk. But yeah, so worth looking at that. But definitely that dual tasking, be careful you don't overload them, and give them space to do one thing or the other. And then the flexibility, the stretching, because we're talking about these muscles aren't switching off. So they're not getting the relaxation that the rest of us are getting. So tend to get quite tight elbows. So making sure you get end range movement when you're doing stretching work with them. I know you guys are brilliant at doing warm-ups, really good warm-ups. And the poles are great for that, getting end range, arm extension, all sorts of things. So yeah, just making sure that you get to the end of the range. I think people with Parkinson's tend to lose a bit of understanding of where their body is, which they can't always work out how far they are extending. So that cueing, verbal cueing of, hey, a bit further, or right to the end, or really helps work out, or what does big feel like? We often use that phrase, what does big feel like? Right. So so yeah, it's just some ideas. Look, I think that's even Martin. I must have nicked that off some website, Martin. There we are. So just think of things you can do, speed and power, really good. We're always saying, hey, let's look at that powering up behind a movement, get that oomph back behind a movement. Strength and power. Yeah, we're a big fan of TheraBands, functional strength stuff. So using your own body weight. You guys, great squats, anything like that to really work on keeping that power and strength. The dual tasking, so this coordination element, definitely, and poles are really good for that. There's other gadgets you can use. Yeah, getting them to dual task is quite a good challenge. So get them to count backwards while they're walking, or there's loads of brain games you can play. That's good. There's flexibility and balance. Yeah, we do use Tai Chi. There's loads of things you can do for that. Balance. I love cones. I don't know if you have other kit in your arsenal, but yeah, doing anything where you're having to touch out of your base. So trying to get them out of their base, really helpful. Great. Okay, so we're nearly coming into land. So just these pointers for, it's not Nordic walk, pole walking. Sorry, guys, pole walking and Parkinson's. So think about this rotational element for upper limbs. So, so for your trunk, for the upper limb. So trunk stiffness is a problem. Make sure you get this rotation in, get them doing a load of rotation exercises, really good, and extensors. So the other thing that happens with Parkinson's, in some forms of Parkinson's, you get these really weak back extensors. So they end up not being able to extend to stand because their muscles in their back are acting as if someone's cut the tendons. So when they did some muscle biopsies of these patients, they have something called camptocomia, which is this forward leaning. The muscles are acting as if they've been cut and they're not now attached to the body, even though they're still attached to the body. So there's something we don't know yet why goes on with Parkinson's in some people, and you get these really weak back extensors. They're not working. That's incremental over time. So you guys are the perfect people because you can get them on poles, get them up, get as much muscle activation as you can for as long as we can. So yeah, really good. Foot placement, we've just talked about that. The muscles on the inside of your leg tend to pull across, that we call that dystonia. So yeah, working on where those feet are going, really lovely practicing for that. Stride length. So Parkinson's wants to make you small and we want to make you bigger. So cueing, we call, so verbal cueing. So say, big stride, like big steps. Looking at like trying to step over things, so keeping that stride length. Heel strike, so you're not just popping that foot down, really get that heel strike, so you're getting to lift that knee. We often talk about not turning by just swinging yourself around and crossing your legs over. That is a really tempting thing to do when with Parkinson's, because you just want to get somewhere quick. So marching around, lifting those feet, being able to make sure you can make those feet move. As your Parkinson's, with some people with Parkinson's, you can get a condition element which is called festinating, where for some reason the body suddenly goes into this quick walking pattern. And the advanced stage of that can often be that your feet totally freeze. So if you've lack of dopamine in the system, just means you just run out of that ability to move. So both of those things are really frustrating for people with Parkinson's, and obviously really messes up their balance. So the risk of falling at that point is huge. So teaching that big stride length, teaching those big steps so they can get themselves out of trouble. So reintroduce like that powering up to be able to step is really key. So lots of walking around, really practicing good behavior when you're stepping around, and turning is that problem. So practicing turning is really important. So walk them one way, turn around, walk them back, keep going backwards and forwards. Head turning, so I'm all into that at the moment, this vestibular thing, what's going on with the vestibular system is really interesting. So making sure you can walk and head turn, just practicing that. That becomes a real problem as the Parkinson's becomes more advanced. So it's worth practicing early. And then balance training, which you guys are great at. And it's because where the body is in space, all this information that's coming up, we need to keep the body understanding where it is. And the more practice you can do, the better. So there's loads of things there that aren't even to do with, movement, are there? You can do that on the spot, but all really key and part of what makes up this 150 minutes of exercise. Just some practical implications. Technique matters, which you obviously all know. Don't be a perfectionist with people with Parkinson's. They need to move. So the best thing to do is for them to move. So if they're with you, just get them moving and teach good technique to really help with problems that might occur. But it is just really important that they move. Frequency matters, says the research. So 3 sessions a week. they did a research study, 3 sessions for 96 weeks, made a real difference for people with Parkinson's. So make sure it's sustainable, try and make sure people are keeping coming. Safety and client selection. Yeah, I've just had a reshuffle of my classes because some of the patients were really freezing and I just needed to move them into a safer environment, and I've had to reset a class. So it is hard to have those conversations, but really important because it means that they'll feel much safer if you reset them into the stage they need to be at. Especially because this freezing of gait is a real complicated one, and it does need to be, it needs to be looked after. But keep them moving, just keep them moving. And then, and just keep having conversations because things do change. And you can definitely have a conversation with them. Have they seen their Parkinson's nurse recently? That's, the holy grail at the moment. But the gold standard is see your consultant every year, see the Parkinson's nurse every year, but in the 6 month off. So it's 6 months, see the Parkinson's nurse, 6 months, see the consultant, So that is, so if they haven't, see if you can help them to lean on their team to be seen. And then, loads and loads of great ideas of places to go to. So there's some really good podcasts. Movers and Shakers are, a bunch of professionals who've got Parkinson's who talk about loads of things. They get loads of research people on. 2 Parkinson a pod, there's 2 guys that've got Parkinson's. The Scotland Research Pod is my friend Julie Jones. There's your free gym memberships for everyone active in Pure Gym if you've got Parkinson's for you and your carer. So send them in that direction, and then they're doing even more exercise, which is great. We do loads of work with Parkinson's UK. There are loads of videos on the Parkinson's UK YouTube channel. I think WALX is on there. Martin's got a video that I often send to people, technique on walking. So go and have a look at their YouTube channel. Sports Parkinson's are brilliant. They'll give you money to help you set up a class. So they are all about helping fund exercise professionals to get classes started up in your area. It tends to be seed money, so you'll have to have a kind of way to keep going after that. But really helpful. Have a look at Sport Parkinson's. They do something called a triathlon, which is a try. Come and have a try. So anyone with Parkinson's, come down and have a go at a load of sports. They had it down in Twickenham this summer, so keep an eye on what's going on with the Sport Parkinson's team. And then, loads of hubs in maybe potentially in your area, and clinics, or the NHS setup. And then my go-to when I'm thinking, what should I do for balance exercises? What should I do for head to these people? NeuroHeroes and Reach Your Peak do private online classes, so you could send your people to some extra work, so you're not having to do all the work for them. They're great. They're both based in the UK. And then PWR, a brilliant American group. PD Warrior are the Australians that do loads of exercise. LSVT is an American lot. I should have put it on here. Power for Parkinson's, if you want to write that down. They're the best YouTube lot I've ever seen, so they're great at ideas for classes. So Power for Parkinson's. Right, that's enough.
Wow.
Ask me some questions.
Okay, well, thank you. That was just amazing. And actually, throughout that, you have answered some of the ones that we got in beforehand. So I will just ask those people if they have been answered fully. But a couple of things that came up in the pre-questions, and then we'll go to some of those that have come through while you were presenting. We were sort of concerned about how many people were saying they really wanted to come to classes, but the time of day was wrong. And I wondered if you got some advice around what time of day is best for people with Parkinson's, both if they are someone living with the condition, or perhaps, you're putting a class on and you might not realise that you've got the timing wrong.
Yeah. So I have a beautiful clinic because no one wants to see me before 10, so I can get a load of admin done, because if you've got Parkinson's, early stages, you're absolutely fine. But as the condition comes, you're pretty stiff in the morning and you need time for the medications to kick in. So so it depends. If you've got a young onset bunch, pretty fit, they'll come before work. They'll love you if you do it at 8. But other people will struggle, especially as you get further down the condition. So mid mid-morning, mid-afternoons, really good. And it's worth a conversation with them actually, and even just say, hey, where are you taking your meds in the day? And maybe if you notice like actually they're wearing off towards the end of the session, could say, hey, there's a dispersible medication, Madpass dispersible, that consultants will often give people to take if they're going to do some exercise, and say, hey, you could top up with this. So there are ways of keeping them going for your class if that's appropriate for them. And their Parkinson's. So yeah, it's worth the conversation. But yeah, mid-morning, mid-afternoon, they might not love you in the evening unless they're still young onset, and then they'll take all the classes they can get. So yeah.
Fantastic. And Julie's confirmed that her group seemed to like 11 a.m. and I know locally 10:30, 11 a.m. seems to work for us as well. On a similar note, the weather. As we're going into cold weather, Emma, one of the instructors and also a participant, has asked, is there anything they need to avoid going out in the cold, or does heat or cold affect their ability to exercise effectively?
Yes and no. And that's the brilliant thing about Parkinson's. Everyone's different. And so some people will tell me, it makes such a difference going on holiday. I think probably like any condition, hey, and especially arthritic ones, definitely rigidity, it doesn't love the cold. But it isn't specific. I think what you tend to find is they have these kind of internal tremors that can really bug them. Not everyone does, but they can do. So you might not notice that they're feeling like, their legs really burning or really sore or really, and changes in temperature, those and times of day can really affect that. So I think do ask them if they're willing to talk to you about it, because it's really good to get to know their bodies and find out, hey, what are the things that are bugging you and what helps and what doesn't. And I'm learning things all the time, and ideas around compression. Sometimes if they're getting real problems with internal tremors, like compression bandages are quite useful. Rubbing, putting your foot on one of those really spiky balls, really helpful. So changing, there's something to do with giving them back some sensation. I think that that limb doesn't almost know where it is, so you can give it a bit of support, either with a compression something or massage, or it helps. So all those things are really handy, and they'll find some stuff themselves that might work.
Fantastic. And a couple of people have brought up, I think probably instructors have said that people struggle with slopes, some uphill, some downhill.
It's
Recommendations around that?
It's really interesting. I think I've done my most damage early days, like finding out about Parkinson's when I hadn't clocked that some of these Parkinson's plus conditions, so the ones that are going to get worse more rapidly, they really struggle with cambers. So I had a patient that had MSA, they have no idea where the middle is. So they'll just head down a slope and just keep going. And you're like, oh, my actual word. And it isn't always up and down. It's often the side, when you're going sideways down into the, and they can't control that. So I think watch it like a hawk. If you've got someone who comes to your group that does really struggle with cambers, or really, and I think it's going down a hill, much worse. It's almost this vestibular system doesn't know where they are and can't control the speed that they need to go at, which is why poles are brilliant, actually. People that I'm really concerned about, I'll make them walk with poles because they can put them in front of them and it just slows that pacing down. I've asked people to go down sideways. That's a really good, don't go down the hill that way, because they just can't work out, and they'll pick up speed rather than slow down, which is a real risk. So yeah, I think that that's a really good question, actually. And it probably flags up, this might be worth them keeping close to their consultant. Things might change. Not always the way. And some people don't have any problem with any of it, but yeah, that is an issue.
Yeah, it's certainly, it's come up twice within the questioning. So I hope that has answered. Some of the questions we got beforehand was, are there specific drills that you feel help with freezing and big movements? I think you answered most of that, but Curly, another instructor, has said, is there anything that you could particularly put into a walking session for on the go that particularly would bring in some big movements and potentially help with freezing?
I
Yeah.
think fluid intake.
Yeah, thanks, Karen.
That
Yeah.
is really very important.
Okay.
Unless because I find with my husband that he's had to go, he's gone to bed.
Yes, yeah, yeah, you see? Don't keep them up.
No.
But he was here for a short while. But fluid really helps because it helps with the medication and the medication to work and things like that. But I also find, because he's got a little bit of dementia, that when we're going out in the morning for the exercise session with Emma, that he gets anxiety because of his dementia. And but once he gets out and he's had fluid, he is absolutely amazing. He can walk faster than most of the people who haven't got Parkinson.
Yeah.
He becomes a different person.
I was just looking up, and that's why, sorry, I just YouTubed and then it's come off on the thing. Rachel Flanagan, so if anyone wants to write that down. So she's a dietitian with Parkinson's who's just launched a nutrition for Parkinson's website alongside her. I think it's My Move Matters is her website. She does a brilliant conversation around nutrition, which involves you need to take 300 mils of water each time you take your medication. No one does that. They'll down it without anything, or they'll take as small amount as they can, and that's because it's much better, obviously, being absorbed. But so yeah, this conversation around fluids also for the postural hypotension patients. Definitely get them to drink as much water as they can before they start class, and you'll probably get a really different class out of them because they're anxious about their bladders. They don't want to drink.
No,
but
he doesn't.
Yeah, exactly. Yeah, I mean, same with all of us. But yeah, I definitely feel that the conversation around fluids is coming because Rachel Flanagan's done some good work recently. That she did have a video about it. You might find it on her website. But yeah, yeah, it's definitely worth signposting people to. There's some really good work on.
Yeah.
nutrition.
So thank you so much for that, Karen. That's fantastic, and we'll try and find that. We just got a couple more minutes. I think I just wanted to check. Lance asked about pole walking and arm and leg coordination, and I think you answered it, that sometimes it's just not right for people. But I did want to flag up, we've got some great little videos of Martin going through some phases, so you might be able to use poles for some stability without having to think too much about coordination. So if there's some way, even indoors, that you can get that stability and that you're standing and walking. So I've got your email. I'll share that. If we haven't answered your question, come back and I'll pose it in more detail to Beccy. And on a similar note, Barbara, Paul, her husband, was diagnosed in 2018. I know he's been to a lot of events over the years and has kept walking, but sadly he doesn't leave the house as much now. And Barbara's saying, it was about resources, but are there any specific exercises indoors that he can now do? And you referenced the videos that we did for you, which are for indoor.
Yeah, there's loads out there. The Power for Parkinson's video, you can do that till next millennium. There's so many on there. And there's loads of seated ones. And actually, they did one with poles that I love, that I just downloaded for a patient the other day. So maybe you guys also, Martin, have you got some seated ones, Martin? Anywhere, seated videos?
They weren't seated, but I know I had to be the person that was holding on to something. Okay. So
we'll ask Martin.
We did 3 levels.
Okay. So maybe that's something else to do. Yeah, I'm sorry, I was just picking up on freezing as well. So exercises for freezing, yes. I really like floor spots. I'm a big fan of floor spots. So getting people to target onto and back off and sideways and kind of points of the compass. There's a really clever app called Clock Yourself that you can download for £3. And it's life-changingly good because you can make it really fast, which is impossible, or really slow, which is easy. And it just takes you around the clock and you're stepping out onto a kind of virtual clock face on the floor. That's good. You can do that in a group. So we often use that in a group and just stick it through a speaker. So freezing really is about finding the thing that helps to cue. So like a talking, a 1-2, or a left-right, or a vibration gadget. anything like that. But then teaching them to be intentional about the step, but also where the balance is. So when you're freezing, your weight's forward, and you've got both feet flat, so you need to weight transfer to get one foot off to move again, and they're stuck with the weight down through both feet. So always get them to weight transfer laterally. So practicing a lot of that, which you can do beautifully with the poles. And then it's the step. So I try and teach them like a rock sideways and then a step. And then you're hoping the muscle memory for when they do get stuck, they can unstick themselves. It isn't perfect, but yeah. And yeah, so that kind of thing. I think having something to cue that's on the floor often is really helpful. They can step over or step on. We're often putting floor spots on people's floors at home that they step through. Door frames are a nightmare. So yeah, putting a spot on the other side of a
Door frames
door
are
frame.
very difficult.
Yeah. So
We do 1, 2, 3, and
yeah.
that helps. But
Yeah.
everybody has that, because you can go through a door and you can forget,
Yeah.
can't you? It's a very normal situation.
Yeah. It's and the inattention. So yeah. So there's anyway. Clock yourself. Freezing. Yeah. When they're early days, I get them to do chair to chair. So stand up, turn around, sit on a chair. Stand up, turn around, sit on a chair. It's much harder than you think to do that, and that really stands them in good stead for when that becomes a real tricky one. We're running out of
Brilliant.
time.
Okay, we are running out of time now. There's one final question. Tracy asked, can people regain if they've lost trunk rotation? Is it possible with focused working with poles and other exercises? Can it be regained?
Yes. I would like to say it's always me, and then they tell me they also change their meds a bit, and I think, oh, okay, fine. So yeah, the annoying thing about medication is if they are sensitive and it does work, it really does work when you put them up on it. So with dystonic feet, we're always trying to you might find the new onset patients, they'll walk for a mile with you and then they'll suddenly get a really clawed foot and they can shake it off. But then it might start again. And we try everything to decondition that foot and do loads of clever work. And then they just go off on their leave a day for a bit and then it's fine. And I feel a bit sad about that because I'd like to cure it myself. So yeah, so if there's problems, talk about their meds, but also you definitely can make a difference. And a lot of it is muscle memory. So then they just get their muscle memory back. Yeah. Good.
Fantastic. So there's some other resources that people have shared. Lots of praise for this, Beccy. So thank you so much.
Great. Yeah, do send me any other questions. I'll pop my email on.
And so a couple of people have said, one said they use Emmett and Bowen techniques, and somebody else has shared some resources in Wandsworth, if anybody's in that area. Yeah. What we'll do is we will make sure that all of that is available when we share the video on our YouTube. And somebody else did say something, another method that, and a podcast from Alan Alder, which includes what to do with exercise and Parkinson. So lots of sharing, which is great. Thank you all so much. We could have gone on for hours, but Beccy needs to get her tea.
That's fine. I was just going to say, actually, send people to Parkinson's UK there's a map which tells you what exercise groups is around in the area. If there isn't anything, just get one set up. Make sure you are on it. If you're an exercise provider, you can speak to Parkinson's UK, get yourself on it, because we really do need everyone to know where you are.
Yeah, and that's the same with us at WALX. We're always looking for more people to put groups on.
Yeah, so onto the WALX.
And we've got lots of online resources for people to help you deal with and put on walking classes for people. So please get in touch with us. We want to help as many people as possible to stay on their feet and keep smiling. So thank you so much.
Gill, can I just pop in at this point? We are doing some work with Parkinson's UK. If you are an exercise provider with a Parkinson's group, we do have some funding available to set up a WALX group. We've already secured that funding, so please drop Gill an email and then we can get back to you.
Yeah.
I've also got to say that Emma White in Warwickshire, she is amazing what she does for people with Parkinson's, because I'm on the Parkinson committee, and I can tell you that what she does for our Parkinson members is just amazing. We've had some members who could barely walk before she was looking after them, and they are now really walking with purpose, and it's amazing.
Yeah, it's
So
good. It
what
does
you're
make-
doing is absolutely fantastic.
Thank you.
Well,
Thanks so
thank
much.
you for all doing it too. Thank you.
Yeah.
Yeah,
Thank
they're
you.
absolutely
Thanks for
amazing.
sharing that. Cheers. Thank
Okay.
you all. Bye.
Bye.
Bye-bye. If you
Bye.
just